Hello everyone, my name is Elario. I'm an intensive care physician and the student of the Principles and Practice of Clinical Research, and I am analyzing a paper from my field as a bonus assignment. I chose acute respiratory distress syndrome since it's a challenging condition of the intensive care unit, and it became much more noticeable after the pandemics, since it was the leading cause of death of patients affected by COVID-19. My aim today is to guide you through the disease definitions so we understand the study design and analyze some aspects of the trial, such as randomization and blinding, and draw some conclusions out of it. ARDS is a prototype of an inflammatory disease, since the entire harm is caused by this effect of cytokines increasing permeability and causing alveoli to collapse. Our challenge is to ventilate a lung that is heterogeneous because part of the alveoli are collapsed, congested, flooded, and other part might be normal or even overdistended. What level of pulse and expiratory pressure is ideal for a lung that part is collapsed and part is overdistended? The overdistension is harmful for it will cause more inflammation, and also the cyclic opening of unities may also cause trauma called athalate trauma. So the ventilator-induced lung injury might be caused by both the overdistension and the cyclic openings of alveoli unities. So in order to understand how the trials will assess ARDS, we'll go quickly through the definitions, the definitions from 1994 and in 2012, just to understand how are we assessing this pathology. The definitions of acute respiratory distress syndrome include timing. It has to be acute. Includes imaging. The lung opacity is seen either chest X-ray or CT scan. The origin of the edema is important to be addressed in order to rule out cardiac causes. Last but not the least, the oxygenation will help us to divide the patients into severe, moderate cases in order to better understand the implications of ventilating them. Is the ventilation strategy for a moderate patient the same of the severe cases? Is there any other way to separate, to cluster these patients, or are these definitions enough? The entire strategy of managing ARDS revolves around the post and expiratory pressure. That is the pressure that stays constant along the ventilation and is supposed to keep the alveoli unities open. So this study compares a regular high PEEP strategy compared to a massive recruitment strategy that was believed at the time that it could be beneficial since it would have an impact on opening collapse alveoli unities. However, if you may remember that some unities are overdistended, would that be harmful for the already opened and overdistended alveoli unities? And we go back to the start question. What's the right amount of pressure on the ventilation that will be beneficial for the patient go through the condition the best possible way. Let's go over the population intervention comparator and outcomes in order to understand the choices of the study. So the population was patients receiving invasive mechanical ventilation. And these patients were in an acute setting. The exclusion criteria were basically criteria of stability, of hemodynamics, and intervention was this massive recruitment maneuver with pressures up to 45 centimeters of water compared to the regular decremental titration that starts at a much lower level of pressure in order to keep the collapsed alveolar units open and compare whether there was a difference between the intervention and the control group. That is the widely used ARDSNet strategy based on the displayed table. The primary outcome is a 28-day mortality. As for the secondary, includes length of ICU and hospital stay, ventilator-free days until day 28, pneumothorax requiring drainage, translating into barotrauma, in also barotrauma in 7 days. One thing is related to the other, and this 6-month mortality, intensive care related or hospital related, not to mention other exploratory outcomes. So far, we have a population that is representative of the regular adult with moderate to severe acute respiratory stress syndrome. The outcome is a clinical outcome, which is much more relevant than surrogates, which is the 28-day mortality. In order to account for external validity, it is important to remember that this trial included 120 intensive care units from 9 countries, from South America, Asia, and Europe. Of the 2,077 eligible patients, 1,013 were randomized. Due to the nature of the intervention, it is impossible to blind the physicians administering the ventilation. However, the randomization was a block stratified randomization with blocks of 4, and the allocation concealment was ensured via a central web-based system. And also the list was generated by someone with no clinical involvement in the trial. So the allocation concealment was excellent too. In general, this study provided many details on the entire process, which also helps to ensure the validity of it. Interestingly, the study concludes against the recruitment maneuver as it increases the 20-day and 6-month mortality and also increases the risk of pneumothorax requiring drainage and the overall risk of barotrauma, which we do not want in our intensive care units. So even though the study shows negative results, it strongly advises against the intervention. And after this huge trial, it is basically buried the idea of trying this massive recruitment maneuver. The patient with acute respiratory stress syndrome could be further divided into groups regarding the lung compliance. Some will have much difficult compliance than others. May these subgroups change the way we could interpret the recruitment maneuver? We are not able to know based on this study. However, the results are robust to advise against this maneuver that will increase the barotrauma and also the mortality. Thank you for your attention and patience while following me throughout this little tour on an example of how a study with negative results also may impact the clinical practice.